Hello everyone, good evening, and I hope I'm audible and visible to all of you. And if the stream is going on well, do let me know.
Hello everyone, good evening.
If the stream is going on well, just give me a quick confirmation in the chat box below. Good evening everyone, and yes, I'm sure that you've done a tough job today of writing the INI-CET examination, and I am not really sure how the paper was, but at least what I know from the little first-hand information that I've got, that the paper was on a relatively, not so difficult side, but I would say a little simpler side of the question paper. So there were quite some topics where there were a lot of repeats, like the topics were repeats, but I wouldn't say the questions were direct repeats. The options were a little tricky is what I got to know from the students. If that's the case, I mean, you guys are really lucky because the topics, if you had learned well, then I'm sure you did your exam really well. So first of all, congratulations on successfully attempting the examination. And now that you've attempted the examination, do not overthink about it. You may attend the recalls, you may understand how much you might probably get your scoring for, but don't take it too much to your heart right away that, what if I don't get this marks or what if I don't get that mark. Don't think about it right now. Just be cool, calm and relaxed, and whatever has to happen will happen. And also we know that this exam is an attempt for our NEET PG also, because we are writing this exam because we want to do our best or better in the NEET PG examination. And if this is done really well, then that's of course a very good thing to do. And first of all, how are you all? How have you attempted your examination? Let me know quickly in the chat box below before we start the recall. Okay, great guys. So how have all of you performed your examinations? I want to know from all of you in the chat box below, and I'm waiting for that. Meanwhile, let me give you a quick disclaimer of why we are doing this recall session. Basically, the motive is to get the actual questions which have been asked for. This is a recall given to us by few of our students, the few students of mine who've attended the examination and given me the questions. So based upon their feedback, the questions have been, compiled together in a PPT, and that is what we're going to discuss. But if there have been changes in the question or the language of the questions or the options of the questions, then of course we are open for discussion for all of it. And it would be nice if you can all interact during the session so that I will get a more, accurate recall of what was asked in your examination. Hello, Nikhil Singh. Yes. So let's begin with the first question. Okay, so I hear from Rudransh that it was an image-based, more on moderate sort of a paper. So I think that's what most people even told me, that it was not very difficult, ma'am, but it was ठीक है moderate type PY topics, previous year topics. If you've done kiya hoga, so of course you must have done reasonably good paper. Right, so let's discuss the first question. This is a question which says that a patient presents to the OPD with complaints of vertigo, which was sudden in onset. So there is complaints of vertigo, and this vertigo had been sudden in onset, associated with sensory neural hearing loss and tinnitus. This was accompanied with nausea, vomiting, and specifically they have given you vagal symptoms. They have also given that the investigation there is showing to you endolymphatic hypertension. What is the diagnosis of this patient? Okay, so I think this is a very easy question. Kuch bhi nahi hai. Even if you have this audiogram, if you see the audiogram, you would know the answer. Even if you don't know the audiogram, the symptoms, I have taught this time and again during the classes that vertigo lasting for minutes to hours is going to be Meniere's disease. Seconds to minutes is BPPV. So this is like a characteristic question that we learn on and off during our entire discussion. So this question was, I think, a cakewalk for almost all of you. So I think this is the right answer is going to be the Meniere's disease. If you think this was not the exact question and if there was a change in the language, please do write in the chat box so that we will be able to give you a more accurate question and answer, and that will be uploaded onto the app very soon. So please let me know if you think that these were the options or not the options, or if there were different options. Please comment in the chat box below. Yes, so otosclerosis was an option, NIHL was an option. So there's many of you are telling Meniere's was not an option. So if Meniere's was not an option, if they had given to you noise-induced hearing loss. Okay, so they had given you noise-induced hearing loss as one option. Okay. Cochlear otosclerosis as other option. Okay, the next, endolymphatic eye drops was an option as per Webhub. Okay. So if endolymphatic eye drops is there, then that only will be the answer, because endolymphatic eye drops is another name for Meniere's disease. So whether it was endolymphatic eye drops or whether it is Meniere's disease, I think that will be the, that will be your answers. And acoustic neuroma is your fourth option. So 1, 2, 3 and 4, these were your 4 options. This is what I understand from the comments mentioned in the chat box. So if they had given to you endolymphatic eye drops as an option, you can take this. So there can be different options for the same Meniere's disease. So they can give you cochlear eye drops or cochlear Meniere's, they can give you vestibular Meniere's, they can give you Lermois syndrome, they can give you Tumarkin's otolith crisis, which are variants of Meniere's. So whether they had given you directly Meniere's or endolymphatic eye drops, then that is straightforward your answer. If that was not the option, then the rest of the options would possibly be either Lermois, either cochlear Meniere's, or either cochlear eye drops could be the option, vestibular Meniere's or Lermois syndrome. So if any of these words were used in your options, then that is going to be your answer. Okay, so I think now it is right as per H. Nana. So the options which I've given right now after compiling from all of you, I think this was the correct set of options. So anyways, the answer is going to be endolymphatic eye drops or the other options or the other names for Meniere's that I have mentioned to you. Now just because we have this thing that we have taken this in our revision sessions on LRR and the rapid revision which is there on PrepLadder, I have just put up these recall slides which have been done in the LRR session of last month, where we took up these topics. I've discussed Meniere's disease. I've typically shown you an upsloping graph. I've shown you air conduction and bone conduction were abnormal and there is no airborne gap. And if you see an upsloping graph, think of Meniere's, and the same upsloping graph is given here in the examination hall. So I think this should have been a good catch for all of you. So here I'm not claiming my strike rate, but it is here just to emphasize the importance of attending the classes, which would probably help you in your final examination. Right, so let's go to the next question. The next question is, a patient presents to the OPD with complaints of bilateral hearing loss with worsening of right ear. So they're saying there is a bilateral hearing loss and the right side is having more hearing loss as compared to left. On examination, the doctor diagnosed it as otosclerosis and recommends stapedectomy as the final resort to the problem. What would be the findings of the tuning fork test based upon the doctor's recommendation for stapedectomy? So I think this is a question where they had given you a scenario of otosclerosis and expected you to know the tuning fork findings that would happen. So if they have given to you that there is a bilateral otosclerosis and there is a right-sided hearing loss which is more than that of left side, what would be the tuning fork finding? So I'm waiting from all of you in the chat box. What do you think would be the tuning fork finding? Rene would be positive and Weber lateralized to the left ear. Rene would be positive, Weber lateralized to the right ear. Rene would be negative, Weber lateralized to the left ear. And Rene would be negative, Weber lateralized to the right ear. What do you think would be the answer? So whenever we are talking about otosclerosis, there is a first very important thing that we need to know, that in otosclerosis, there is a conductive type of hearing loss. And whenever there is a conductive type of hearing loss, we know that Rene will be negative. So whenever there is a conductive type of hearing loss, Rene is going to be negative. So bilateral conductive hearing loss, so means bilateral Rene will be negative. Now they have clearly mentioned that the right side hearing loss is more than that of the left ear. So what would happen to the Weber? Weber would get lateralized towards the disease side. Whichever is having more disease, the Weber would get lateralized towards that side. So what would we see here? Weber would be towards the right ear. So the answer would be Rene's test negative and the Weber's test lateralized towards the right ear. So I think that many of you, Aditya, Rudransh, Nikita, all of you got it right. Yes, so I think this question, all of you would agree that this was probably the similar question and the language stands to be very similar to what was asked in your question, and I think it's a pretty easy, simple question which was quite expected. Yes. Okay, so if you see here, we have discussed again this, that whenever there is a conductive hearing loss, we will see that Rene will be negative, and we've also discussed that if there is a Weber going to right, it means that the right-sided hearing loss is more than left. Again, this is a recall which we have done in the LRR last month. Okay, now let's go to the third question. Okay, so Ravi, I think you're telling there was a gap in the AB graph. So if you have air conduction and bone conduction both being affected and they're not in the normal range of 0 to 20, and if there is a AB gap, it means that the patient is having a mixed hearing loss. He might be having conductive and sensory neural type of hearing loss. But the clinical scenario with vertigo lasting for minutes to hours associated with vagal symptoms, all of that is very specific for Meniere's disease. So I think even if there was a mixed hearing loss in this patient, there can be inner ear issues with a middle ear or an external ear issues can be present. So Meniere's disease is not necessarily always going to have, sensory neural pattern. That is the highest pattern that we see. But rarely we can also have a mixed hearing loss. But even if I take that your statement is right, even in that case, the symptoms and the clinical scenario is more towards Meniere's disease. Okay, dear, I hope I got you right. Okay. So here is the next question. A patient presents to the OPD with complaints of hearing loss and can understand only shouted or amplified speech. What will be the degree of impairment according to the WHO classification for ability to understanding speech? So typically when we talk about classification for hearing loss, what we typically discuss is the American Speech and Hearing Association classification. This is what is commonly used, but WHO classification is also something that we commonly use in our classification system. Now WHO classification is basically divided only into 4 types. It has mild, it has moderate, it has severe, and it has got profound. So let us understand what is mild, what is moderate, what is severe, and what is profound. Can you all tell me what is it? What is mild, what is moderate, what is severe, and what is profound? Can you all tell me very quickly? Okay, I'll discuss this with you. What is mild, what is moderate, what is severe, and what is profound? So typically as per WHO classification, 26 to 40 decibel hearing loss will fall under mild. And then you have 41 to 60 decibel, that is moderate. 61 to 80 decibel is going to be severe, and more than 80 decibel is going to be profound. Now this classification you know, but they have not given you about the decibel of hearing loss. They have told you that the patient is unable to understand or hear and is able to understand only when the patient is when we shout or if it is amplified. What does that mean? Our conversational speech is always up to 60 decibels. Like when we speak, it is 60 decibel. That is normal conversational speech. So if we have to shout, we have to increase our volume beyond 60 decibel, which means patient is having a hearing loss greater than 60 dB. So this word, when the patient or whenever he is only able to hear on shouting, that is indicative that the patient is having more than 60 decibel hearing loss. So based on that, if it is more than 60 decibel hearing loss, where do you think would the patient fit in? Okay, so I think that the answer now all of you would know, this is severe hearing loss. Okay, so I think this is quite clear to all of you that this is a patient who had severe hearing loss. This is a chart again discussing with hearing loss when we've done it in the RR. Okay, now let's see the next question. I think this is a basic cakewalk for all of you. I don't think that there is much of scope for discussion. Whenever you see this image, you know this is a previous year topic, previous year repeat. It's something that you see on and off, even on Instagram, even on Telegram. Everywhere this question is a constant repeat. So can you all tell me what is the diagnosis? I don't think I have to even read this question. Of patient presents to you with bleeding from the nose, nasal obstruction, difficulty in breathing. He gave a history of bathing into a local pond. On examination, there's a red polypoidal mass with whitish dots on the surface. What do you think is the diagnosis? I think this is pretty simple question. I know all of you know the answer for it. So quickly give me answer in the chat box. Yes, Dr. Sneha, you're absolutely right. Absolutely right. The answer is rhinosporidiosis. You can see sporangia with spores inside. So when you have sporangia with spores, it is suggestive to you of rhinosporidiosis. And typically the history suggesting to you of bleeding, nasal obstruction, waterborne infection, because the patient had a history of taking bath in the pond. There is a reddish polypoidal mass, whitish dots on the surface, strawberry mass. All of this is suggestive to you of rhinosporidiosis. So this is something we've discussed again in our LRR before. So I'm not not going to go into it. Let's go to the last question. Okay, so what is the last question? Okay, so even if they didn't give you a history of bathing in the local pond, if they have given you histopathology picture, I think that itself is enough. This is an image-based question which you can spot even without any history. So I think all of you would have done this right. Okay, mark the correct statements regarding inner and outer hair cells. So inner hair cells are single row and transmit auditory impulses. Outer hair cells are 3 to 4 rows and modulate the function of the inner hair cells. Outer hair cells are more responsible for movement of the tectorial membrane. I think option 4 is the same as option 1 because I think this was repeated again. And outer and inner hair cells are present in the ratio of 3:1. So we all know inner and outer hair cells. I have already given you a quick trick of remembering, type 1 and type 2 hair cells. So I've always told you that type 1 means always single. So type 1 are single. One first letter is alphabet A in your English. So it is afferent. It conducts the impulses to the 8th nerve, so it is afferent nerve, so it secretes excitatory neurotransmitter. And then if I write 1 like this as Roman digit, it is called as inner. So these are the things that we have already discussed. So type 1 hair cells are inner hair cells arranged in single row, transmitting the auditory impulses is the correct statement. Outer hair cells are arranged in 3 to 4 rows because they are multiple. They are not afferent, but they are efferent in function. They are responsible for modulating the function of the inner hair cells. So this is also correct statement. Now, are outer hair cells more responsible for movement of the tectorial membrane? There is no such rule that outer hair cells will cause more movement of the tectorial membrane. So this statement is false. Outer and inner hair cells are present in a ratio of 3:1. This is true because outer hair cells are about 12,000 in number. Inner hair cells are in about 3,500 to 4,000. So even if I take 4,000, it is about 3 times that we have the outer hair cells and 1 time that we have the inner hair cells. So these 3 are your correct statements. Option 1, 2 and 4 or 5, option 1, 2 and 5 are correct. This is going to be your correct answer. So I think this was pretty simple of what was discussed in the examination. If you think there were more questions in ENT that came to you in the examination, let me know in the chat box. I'm open for that. So Dr. Gamer, efferent from superior olivary innervated the inner hair cells. That's wrong. That's not the true statement. Inner hair cells do not get any efferent coming from the superior olivary complex. So that's not a true statement. Okay, so if that question is having a little bit of difference in options, please do let me know in the comment section so that we can modify that question. If you think there were more questions in the examination, I'm waiting here to hear from all of you, more questions that were there. So on a preliminary basis, these were the questions that were given. I know that all of you are extremely tired after the examination, so I did not go into the depths of any of these topics, but I just wanted to let you know that these topics were all previous year topics which are all covered, and I'm sure that you did it well, and I wanted to just boost that confidence in all of you that you have read it, you did it well. So I'm sure that all of you got all these questions right. There is very little scope of error in any of these questions from all of you. Yes, so cochlear otosclerosis, some question was there. So Ashwin Kumar, can you tell me a little bit about it? Like, what did they ask you in cochlear otosclerosis? See, cochlear otosclerosis is a condition where you see that the disease is affecting the round window, unlike stapedial type, which is affecting the foot plate of stapes, which covers the oval window. In cochlear type, we have the disease affecting the round window. So there's excessive bony deposition happening at the round window, and here they have sensory neural hearing loss with vertigo with tinnitus. Okay, so that is the clinical features that we have in cochlear otosclerosis. And typically, if you take a CT scan, they might give you a double halo ring. That would be something that could be, asked. Yes. So, if you have got any more questions, can you all let me know in the chat box what is the questions? I'm waiting from all of you. Yes, I'm waiting for your answers. Okay, so incudomalleolar joint is a simple synovial type of a joint. I don't know what were the options there, but did they ask you, was it a hinge joint, ball and socket type of a joint? What did they ask you on that? Can you please elaborate the options for me? Okay, so I think we need to add one question on ossicles of the ear. Yes. Okay, any other question that you think was asked in the exam? Okay, so I think that's about it, and I hope all of you did well in your exams, and I have the next recall that is going to happen. CT image was given of what? Sinusitis with orbital cellulitis. Okay, this is a second question which we need to add. Okay, so what was this question about? CT scan of showing sinusitis with orbital cellulitis? So if they have given to you what is the most common sinus, especially in children, then that will be your ethmoidal sinus that is going to be affected. So can you all let me know what is the probable question that was asked here? Okay, mention the language of the question and the options for these in the chat box, then we will upload this question on our app. We have the next educator coming up for you for discussing the next part of the recall session. I'll take your leave for now. Take care and bye-bye. Hello? Yeah, good. Yeah. Okay, take care. Okay.
Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick nod whether I'm audible and visible, everyone. Just give me a minute to check that live chat. Okay, that's great. So here we are to discuss the INI-CET November 23 that was conducted today, the radiology questions of that. So we have 3 questions from radiology that we would be discussing. So before I start discussing the questions here, first thing that of course I would like to tell everybody of you, I'm sure that many of you might not be feeling so good post exam ki it did not go the way it had to be, because even if the exam is good or the exam is not good, we always tend to feel that, right? So first the stress is before the exam how the paper would be, and then when the exam is over the stress is about ab results kya aayenge. So no matter whatever it is, just remember this one point here, that nobody can go back and start a new beginning, but anyone can start today and make a new ending. right? So nobody can go back and change the answers that you have marked in the INI-CET exam. You cannot go back and reappear for the INI-CET November 23 exam, but you can definitely start today and you can take your NEET PG 24 as your new target, your new goal, and give it a very new and give it a very happy ending. If your exam has not been the way it should have been, use this as a learning lesson, right? It's no point cribbing over it, right? So make sure that from here on you learn out of it. Take your time to analyze, to introspect what are the mistakes that I did in the exam that I should definitely avoid in the upcoming NEET PG 24 exam. And like I said yesterday as well, you know, INI-CET को बोल दो तो तू नहीं तो कोई और सही basically is NEET PG, और कोई और नहीं तो फिर कोई और सही. This is never going to end, right? You are always going to get the next opportunity. No exam is the end of the world, right? The best part, like I mentioned yesterday as well, is the koi or sahi is already waiting for you. It's unlike your real life and you have to go and hunt for koi or sahi ab kaun hoga, right? So unlike that, you will have basically the NEET PG is already waiting for you. So remember that this is not the end of the world. If it was good, that's amazing. If it wasn't, you have the next chance at your NEET PG 24 coming up soon, right? So take a short break. You deserve that break and get on with your NEET PG preparation again. So starting with the discussion of the questions of radiology, a disclaimer here that the questions which we are discussing are just recall based. They might not be the actual questions, but we have tried to make them as close to the actual exam. But still, if there are, you know, any errors you feel, please let us know in the live chat. When we give you the final recall in the app, when we give you the previous year questions, we'll make the rectifications and we'll give you the final recall. The purpose here is not to make anybody feel bad, ki, oh, this was the answer or you mark this. The purpose here is to learn that suppose this question comes in NEET PG 24, what would be the answer? This is for the next batch basically who wants to know ki, how the trend of the exam is changing. And I think majority of the students were happy with the new pattern post exam because you had to concentrate for those 45 minutes only. You were not carrying the baggage of that or ki the tension of ki review baki hai for the entire exam duration. Yes, for some it was a bit difficult. You know, the time management part was difficult, but major response has been like, it was good in a way. We had to concentrate in those 45 minutes ka block itself. So that was the good part there. I hope you were on the good side there, everybody. Please let us know your inputs, your insights about how did you feel the exam was, the difficulty level of the exam and all of that. So let's start with the discussion of the question here. So basically a CT image was given and you were asked whether it is orbital cellulitis, periosteal abscess, preseptal cellulitis, or it is sinusitis also. I believe the input that I've got from the students, the rest of the three options had the option of sinusitis with the rest of the options. Okay. So sinusitis तो basically आपको हर option में दिया ही हुआ है. So first you have to hunt for the sinusitis. So where is the sinusitis? How do I identify sinusitis on radiology? Basically is normal paranasal sinus should contain air. If it is not containing air, that means it is abnormal. Okay, if it is not containing air, that means it is abnormal. Air basically will appear black. So basically the paranasal sinuses should appear black. I can see this paranasal sinus here, right? Adjacent to the orbit, medial wall, we have the ethmoid sinus. This looks normal, right? This is the right side of the patient. This is the left side, right? It's like the mirror image. So this sinus looks normal, but this sinus is opacified. It's not just containing air. And adjacent to that, you can see some elevation there, right? Which is distorting this medial rectus muscle also there. So this is basically the ethmoid sinusitis, and we know very well that ethmoid sinusitis can go into the orbit via this lamina papyracea, that's the medial wall of the orbit, the thinnest wall. So this elevation here represents the subperiosteal abscess. Okay, this is representing the subperiosteal abscess. Basically these definitions, these are based on Chandler's classification. right? These are based on Chandler's classification. So what is the Chandler's classification for orbital cellulitis is the type 1 basically is preseptal, globe ke aage. This is the eye globe. You have the optic nerve here, medial rectus, lateral rectus. So preseptal is uske aage. The type 2 that you are seeing here is basically involving here the orbital abscess formation there. This is just the subperiosteal abscess. If it is just here, the medial wall, lateral to the medial rectus muscle. This is the entire orbital cellulitis, intraconal wala. And the type 5 is where this cavernous sinus is also involved. So in the image that we have been given, basically there is an elevation here. It's not here. So this is not orbital cellulitis. This is the subperiosteal abscess. If this was the image that was given. Okay, if this was the image that was given. So similar to this image that you are seeing here, basically you can see that this has led to the proptosis. Okay, this is basically the proptosis. You can see the eye ka level. Because of this, the orbital contents are basically displaced. Okay, so this is your subperiosteal abscess. Okay, this is subperiosteal abscess, right? So bit of a difficult question in radiology. We have seen recently the questions are more on the the eccentric side, the difficult side, and they are more integrated. They are not like your direct spotter images, but the ones which require a lot of understanding there of the concepts. So at least you could rule out the option ki sirf sinusitis to nahi hai. Okay, because along with the sinusitis, you are seeing something in the orbit, right? So that was the first question there. Coming to the next question, a child presents with breathlessness. On chest x-ray, the following object is seen. Identify whether it is button battery, coin, ball or the bottle cap. Right, so this is again a very famous question. We are asked about this in our radiology residencies also. How to differentiate a coin from a button battery on the x-ray. Why is it important to do so? Can someone tell me why is it important to differentiate whether this is a coin or whether this is a button battery? It's important because the management is different. If it's just a coin in the esophagus and the patient is asymptomatic, we can leave it like that. We can just do wait and watch. But if it's a button battery basically can lead to the erosion of the esophagus because of especially the lithium batteries, the alkaline fluid there, the reaction can occur, the erosion can occur. So remember that this can cause erosion and basically formation of fistula, maybe TEF anteriorly ya piche ja sakta hai. So that is why we have to determine whether it's a button battery or it's not a button battery. For coin, it can be wait and watch if it is asymptomatic. Now, how do I identify button battery? So if you have seen the button battery, those chota batteries, so basically they have two circles. One is the anode, one is the cathode, one is larger, one is smaller. Right, so basically the button battery has two circles. Okay, it has these two circles. One is the anode and one is the cathode. And that is why basically you will see that, okay, that is why you will see in the AP radiograph that it has the sign. You will see a bada circle. If you can see this carefully here, there is one bada circle, there is one smaller circle inside it, telling you that there are two different circles. Here I can see some corrosion also of the battery, right? The reaction that has taken place. So, okay, if it was a lateral view only which was given. So what do you look for in the lateral view basically is the step off sign. What is this sign called as? It is called as the step off sign or basically the beveled edge. Because of that inner circle and outer circle, so if you have two different sizes ke circles, right? Imagine there is one small and one large. So when you see in the lateral side, you will see one small line and you will see a bigger line, and that is why it will have the step off. It is not the equal one. So remember that it is the step off sign, and here in the AP view, this is called as the double ring sign or the halo sign because of the different sizes of the cathode and the anode. And that's why here you see the step off or the beveled edge. Okay, that's the clue there. This of course is in the esophagus because you see, remember the trick, the esophagus wala foreign body, esophagus is O, that's a circle. So on the AP view, it is circular. Whatever is circle on the AP view, it is slit like on the lateral view because it has the step off sign, and that is why these are the classical signs that you would see with the button battery. Okay, these are the classical signs that you would see with the button battery. Okay, metal cap of the bottle, the metal cap will not have these halo or the double ring sign and the step off sign. So the answer here is the button battery. If they would have asked you the management, even if the patient was asymptomatic, you will have to do the endoscopic removal for the button battery. You will never wait and watch for the button battery. So next time you can expect a question on this. Why not a metal bottle cap? So imagine that if it's a metal bottle cap, basically, so in that metal bottle cap, the center part is the hollow part. It's not like the two circles that you would see there. Okay, you will not see those bada circle and smaller circle there. So that is why this is not your metal bottle cap. The classical signs tell you that this is a button battery. Next one, identify the marked ligament. This was the marked ligament here in the image. Okay, this was the marked ligament in the image here. So first of all, this is the MRI, right? Because the bone cortex is black, MRI of the knee, where this is the patella. Okay, so I hope you can identify here that this is the patella here, this is the femur here, and this is the tibia here. So now if you see that this is the patella here. So what do you think? This is the anterior side or the posterior side? Basically, this is the anterior side. Patella आगे होता है knee में. So this is the posterior side of the patient. So logically, सिर्फ आप इतना भी सोचते कि ये anterior है कि ये posterior है, you would have been able to mark the answer. Remember that the radiology questions being asked are such that if your logical reasoning is good, you can crack those questions. Okay? Right. So I'll change the options there, Jake. Thank you so much for the input there. So the options were ACL, PCL, then it was the patellar tendon. Okay, then it was the patellar tendon, and then it was the MCL. I'll show you all the four structures, considering that it could be a potential question for your next exam, the NEET PG exam. Right. Next generally leads to the confusion. So, if you would have thought logically ki when I'm coming from behind, I can see this ligament here. So basically this is the PCL. It is going from the femur to the tibia. Okay, it's going from the femur to the tibia, and I see it on the posterior side. That is why this is the PCL. Where would be the ACL? The posterior and the anterior, remember, is the relation in insertion on the tibia. So the ACL comes like this. Okay, so let me show you the image of the ACL. Look at this image. Okay, look at this image. Coming from femur to tibia anteriorly. Okay, it is coming from femur to tibia yahan pe. Relatively the anterior aspect. This is the posterior aspect. This is PCL. This is ACL. Okay, so this will be the PCL and the ACL basically. ACL comes anterior on tibia, PCL goes behind. Where do you have the patellar tendon? So the option that you should be ruling out the first here is the patellar tendon. Because patellar tendon, as the name says, कि patella पे कहीं attach होना चाहिए. The image that you are given here is not attached to patella anywhere. So the first option that I would rule out is the patellar tendon, because right. So one option is ruled out. That makes me happy if I'm able to rule out at least one option. So patellar tendon will be like this. Okay, so from the patella here to the tibia going there, this would be the patellar tendon. This is the insertion of the quadriceps tendon coming from upar se femur ke aage, the quadriceps tendon. Okay, that's a patellar tendon. What are these structures that I'm seeing here? Basically, these triangular structures here, these are the meniscus. है ना, meniscus आपके knee joint के अंदर between the femur and the tibia. So these are the sections of the meniscus that I'm seeing here. This one here is the collateral ligament. Okay, that's the collateral ligament that you are seeing. Remember, the ligaments, the tendons, the fibrous tissue, they appear black on MRI. So normal ligaments will appear black on MRI. They will not be white. If they are appearing white, that means they are abnormal. There is some edema, there is a tear that we have to look at. So your collateral ligaments basically would be seen here in the coronal or the axial image, attached on the sides of the femur and the tibia. Okay, so if this is the femur and you have the tibia, the collateral ligaments would be here on the sides. Okay, the collateral ligaments would be on the side. This is the area in the center where you would see the ACL and PCL in the coronal image. The collateral is on the lateral sides. Okay, it's on the lateral sides. So in this image, this again, the triangle part, like the bow tie appearance wala, this is the meniscus. Okay, this is the meniscus that you are seeing here. Like you are seeing the triangle part here. Similarly, the triangle part here, that's the meniscus. Okay, so I hope everybody is clear ki why this is not the collateral ligament also, because collateral ligament you would see on the coronal section or on the axial section. It will be seen much better. Okay, according to the orientation, it will be seen on the coronal or the axial. The image that you are given here is the sagittal MRI image. Okay, this is the sagittal MRI image. Is this clear with everyone? So we have discussed the 3 questions here. Basically, first one, the Chandler's classification, orbital cellulitis, preceptal, then the orbital, the subperiosteal. Again, the orbital, which is within the triangle formed by the muscles, the medial and the lateral rectus के अंदर, मतलब वो intraorbital हो गया, intraconal हो गया, right? And the last one here is involvement of the cavernous sinus. Okay, that's the cavernous sinus. Yeah. The next one we had discussed the button battery, that's your double ring halo sign or the step off sign, and the next is the normal PCL that was seen. Can someone tell me where do you see the double PCL sign on MRI? Suppose you have the MRI image where you see like there are 2 PCL. I can see there are 2 PCL in a patient. We have discussed this, and so in our videos also we have discussed this, where I've showed you the normal knee MRI on the PrepLadder app, the radiology videos. Where do you see the double PCL sign, guys? Where will you see the double PCL sign? Anyone? Double PCL sign is seen in bucket handle tear of the medial meniscus. Okay, it is seen in the bucket handle tear of the medial meniscus. That is where you see the double PCL sign. So remember that this is again a potential question for your exam. So if you see the PCL like this, दो जैसे दिख रहे हैं PCL, right? You can see the like the 2 PCL there. Then you think of the, it's basically a bucket handle tear of the medial meniscus. Okay, it is the bucket handle tear of the medial meniscus. These are the normal images that I have shown you, and those were the questions that we got basically from radiology. If there are any inputs or you can recall any other question from radiology, please do let me know. And like I said, again, remember that nobody can go back and start a new beginning, but anyone, trust me, any one of you who wants to start for NEET PG, you can start today and make it a new happy ending, right? So it's never too late to start. Use your INI-CET as a learning lesson, right? And just forget about it if it was not good. And after a short break that you definitely deserve, get back to your new goal, that's the NEET PG, right? So आज नहीं तो कल basically सबका time आएगा, किसी का आज किसी का कल, so don't worry on that front, and just stay patient, stay consistent. Try to control things that are which are in your control. Don't try to control something which is not in your hands. I think that's the biggest mistake that we tend to do. So that was from my side for radiology. If you have any queries, anything that you have any queries कि NEET PG के लिए अब क्या करें, any queries, please let me know in the live chat. Yes, any queries there? So yeah, the next recall session that we have for you is the orthopedics. So that will be up very soon after this. So please stay tuned, and I hope all of you are subscribed to this channel so that you are not missing out on any notifications, the sessions, the productive sessions that we have. A lot of you coming in for your upcoming NEET PG as well. So thank you so much, guys, and all the very best for the results. And yes, that was it for today. Thank you so much.